Hello, I'm Charles Abraham. I lead a research group called the Psychology Applied to Health Research Group in the University of Exeter Medical School, and we do quite a lot of behaviour change intervention, design and evaluation. So I'm going to talk to you about the process of designing interventions and designing in evaluations. I'll talk to you about different types of evaluations and how we plan those evaluations. I want to start by focusing on the results of the House of Lords Science and Technology Committee inquiry into behaviour change interventions relevant to government in 2011. This very useful inquiry produced 32 recommendations for government, which government responded to. But I just want to focus on two of these recommendations. And these recommendations came about from looking at interventions that were available and what we knew about those interventions. And the two recommendations that you can see on the slide here are: first, that we need more research into behaviour change at population level. So how can we change the behaviour of large groups of people? That more research is needed of that kind. And secondly, that when interventions are developed, they should be evaluated. One of the problems that this inquiry encountered was that it identified many potentially useful interventions, but because they had not been evaluated, it was difficult to say whether or not they worked, whether or not they were useful. So I think this is an important set of guidance in thinking about what we need to do in public health to make sure that our practice is more evidence-based. So when we're designing interventions, the first question is, what level is our interventions going to work? So for example, if you were thinking about the problem of overweight and obesity, where would you start? Would you start with individual pupils in a school, for example? That would be, on this diagram, an individual level focus. Or might you think that the best way to intervene would be to change the regulation around food manufacture? So that might mean you were operating at a national policy level or even an international policy level. For example, if you were trying to change European Union regulations. So your target might then be policymakers in Brussels as opposed to pupils in a local school. So it's important to bear in mind that we may need to work at multiple levels if we're to develop successful interventions to change population level behaviour. One of the frameworks that we use is intervention mapping. This has been around for a long time, and in 2016 this book was published, and this is the 4th edition of the intervention mapping framework. And this is a framework that guides you through the process of intervention design and how to build evaluation into your intervention design. So the framework begins by focusing on needs assessment. So why are you doing this intervention? What's the problem? And then it works through the development of logic models, and that's one of the things I'm going to explain as I go along. The design of the program around the logic model, the production of the materials for the program, and then its implementation. And the last stage here is evaluation, but in fact the evaluation is planned before the program is implemented. So it's a cyclical process rather than a linear one. So this is intervention mapping. When I talk about intervention mapping, there's some terms that I'm going to use that I just want to explain very briefly. One is mechanisms of action or theories of change, and this is how an intervention works. How do you change the behaviour? What's the process by which a behaviour pattern changes from one to a new pattern? So, for example, we might believe that by telling people about what other people are doing, that would change their behaviour. So some interventions, let's say around alcohol use, focus on telling people that their drinking is very different to that of other people in their peer group. So this is called changing normative beliefs. Now that's a change technique. It's based in evidence. In some cases it seems to be a powerful way of changing people's motivation and behaviour. So that's That's a change technique based on a particular mechanism of action. Then we can talk about the mode of delivery. So you could do that by giving someone a leaflet, by having a face-to-face meeting with them, and there you need to think about who's going to deliver it and exactly how they're going to deliver it. So interventions differ in the mechanisms of action, which explains how they're going to work, in the techniques by which those changes are delivered, and in the mode of delivery by which they're delivered by different people. So these are all elements of our intervention that we need to get right as we're planning it. I've talked about mechanisms of action. These are built into what's called a logic model, and a logic model sets out the processes of change. That's what the logic model is. And in a moment I'll show you some very simple logic models and some more complex ones. But this approach to intervention design suggests that you need to write a logic model for your intervention at the outset, that it's a key part of the design and evaluation. So the process begins then by identifying the need. And this might require you to do some research with your target audience. So you might want to ask school children about their diet or about their exercise routines, and we call that elicitation research. That helps us understand the problem itself. So that's elicitation research and needs assessment. Then we need to define the outcomes of our intervention. What's it going to deliver? So in this case, it might be that we expect the average weight in an intervention school to go down. So the outcome then is weight loss. The pupils in the intervention will be less heavy when they've undertaken the intervention. So that's the outcome, and that's critical to being able to evaluate whether or not the intervention works. Then, as I've said, we need to understand what the change mechanisms are so we can write those into the logic model. So the logic model might identify what it is we need to change. Do we need to change the information that these pupils have, or, for example, their motivation? And I'll come back to those points in a moment. It's those mechanisms of change that determine what we call a process evaluation. And process evaluations are just as important as outcome evaluations. Once we've designed the intervention to that extent, we need to choose the particular change techniques we're going to use. What exactly are we going to do to change people's information or, for example, their motivation? And then we need to decide how we're going to do it. Are we going to do that by delivering it in classrooms? Are we going to produce a web-based resource? Are we going to use leaflets? Exactly how is that going to happen? And our view is that the best way to design the intervention is to collaborate with the people who are going to deliver it and receive it. So if it's going to be in schools, we need to talk to teachers and we need to talk to pupils, and that co-creation of the intervention makes it much more likely that what we develop can be properly implemented in the context that we want it to be used. And then, of course, we have to persuade people to adopt it and implement it once it is developed, and we need to evaluate it. So there are different kinds of evaluation. The first kind is an outcome evaluation, and this tells you whether or not the intervention worked. So that's why we define those outcomes early on in the design process. So if it's a weight loss intervention, we need to know, did people actually lose weight? So that's our outcome evaluation. Our process evaluation measures whether the change, the mechanisms of change, actually occurred. So let's say our program does indeed lead to weight loss. Did it do that in the way that we thought it would? So that's where we measure the changes that we had predicted. And that tells us whether, not whether it works, but whether it worked in the way that it was designed. And a third very important type of evaluation are economic evaluations. This tells us how much did it cost to develop the intervention, and was it cost effective? Given how much it cost, was the size of effect worth the money? So outcome, process and economic evaluations are often planned together when we're designing our intervention according to the intervention mapping framework. Another framework that we use is the Information, Motivation and Behavioural Skills framework. We find this useful because these are three important targets that an intervention might focus on. We might want to give people more information because we think they don't know what they need to know to change their behaviour. We might want to motivate them so that they really want to change their behaviour. Or it could be that they already have enough information and motivation, and so we want to teach them some new skills. So this framework can help us decide what are the mechanisms of change that our intervention is going to focus on. So let's consider information for a moment. The food that we buy, for example, in supermarkets comes with lots of information on it. So do you know the answers to some simple questions about, let's say, a standard sized chocolate bar? How many calories is in such a bar? Do you know how many calories the average man or woman should be consuming a day? Do you know how long it would take you to burn off the calories in a standard sized chocolate bar? There's some interesting research being done at the moment about what's the best way to communicate that. Is it helpful to tell people about calories? In fact, the research suggests that putting calorie information often doesn't change people's behaviour. But would it work better if we said, for example, not that this chocolate bar is 300 calories, but it would take the average adult 1 hour, 60 minutes, to walk off the energy in this chocolate bar? Would that help people make their decisions more effectively? So that's research around what kind of information we should be providing people with. And in fact, my view is that while people are given a lot of information, quite a bit of that information isn't very usable, and that we could provide health-related information in more usable ways. For example, talking about walking times rather than calories. So 3 general rules about information. 1, it needs to be easily understood. 2, it needs to be relevant to your goals. And 3, it needs to be available at the time that you need it. So when do you need information about the energy content of food? It's when you're buying that food. That's when you need easily understood, relevant information on packaging. Moving then from information to motivation. Motivation has a number of components, but one simple model that we use is this one. Beliefs about whether a behaviour will provide advantages or disadvantages, beliefs about how it's going to make you feel, not just is it good for me, but how is it going to make me feel, beliefs about what other people approve of and what other people are doing, beliefs about who I am and my self-image, and beliefs about whether or not I can do it. Do I have high self-efficacy? Am I confident about doing the behaviour? Those beliefs are all critical to motivation. So one way of deciding whether or not somebody needs more motivation is to check whether these beliefs are already in place. If they are, their motivation may be good. If they're not already there, particularly if self-efficacy or confidence to perform the behaviour is low, then you may need to intervene to bolster motivation, including self-efficacy. So in targeting motivation, we need to look at these components or determinants of motivation and develop materials that deliberately target them in order to have an effect on overall motivation. So are we doing this? Well, some evidence suggests that we may not be doing it. For example, this is a study that we did a while ago, and we looked at nationally available leaflets in the UK and in Germany that promoted condom use. And we asked, what messages did these leaflets include? And did those messages correspond to the kind of change mechanisms that we would expect to increase condom use? And what we found was that the messages in the leaflet didn't really correspond that well to the determinants that we would expect to increase condom use. So in the graph in this slide, for example, the red bars are the associations between, for example, knowledge or perceived severity and condom use. And the blue line shows the number of messages corresponding to that target. And what you can see here is that there are a lot of messages that are about increasing knowledge or increasing perceived severity of sexually transmitted infection or perceived susceptibility. A lot of messages about those, but those are not necessarily the changes that have been found to be best correlated with increased condom use. And the leaflets included fewer messages that would increase self-efficacy or increase beliefs that other people would approve of condoms and so forth. So in other words, the content of the leaflets was not really evidence-based. So the recommendation here clearly is to make the content of your intervention correspond to the changes that research shows is likely to result in changes in behaviour. In this leaflet, for example, which has recently been developed with some of my colleagues in Australia, the idea of this leaflet is to promote eye testing amongst diabetics. So here we used intervention mapping. We interviewed diabetics about why they would or would not take an eye test, and then we identified a series of change targets, and every message in this leaflet is designed to change a particular target which was based on that early elicitation research. Now we haven't yet evaluated this, but we have designed it so that it corresponds exactly to the kind of changes that we think are needed in this population to promote more people taking eye tests. So this leaflet's designed in quite a different way to the leaflets that we looked at promoting condom use. So I've talked about information and motivation, but of course that's not always enough. Sometimes people are motivated, they're very well informed, but they're not taking action. So there's something missing. In fact, if somebody is well motivated, then across studies we could say that about half the time they may actually do the behaviour that they're motivated to do. But if they're not motivated, they're almost never going to do it. So motivation is critical. It's a critical predictor of behaviour. But once you establish motivation, there is usually more to do. There are three particular groups of skills that we might think about providing people with. Just motor skills. For example, how to use a needle, how to use an inhaler, how to take your drugs. These are simple motor skills that we can demonstrate for people. We can provide instructions to increase their competence to do these things. As well as motor skills, we have social skills. So if you're going to change your behavior, you might have to negotiate that with other people. You might have to negotiate condom use or a change in your diet, and that requires social skills which can be demonstrated and taught and practiced, and those may be critical to behavior change. And then finally, a category that we call self-regulatory skills. This is about internal planning and control of your behavior. And some people are much better at that than others. We can teach people, for example, to set goals, to monitor how well they are doing in terms of reaching those goals, providing themselves with feedback. And we can teach them to make very specific plans as to how to deal with particular circumstances that might derail their behavior change that they're motivated to do, how to respond to particular environments in order to maintain behavior change. So these are self-regulatory skills. In relation to self-regulatory skills, an important point to remember is that some of our behavior patterns are very habitual. They're routine and automatic. So we're in a particular situation, we behave in a particular way, and we might even do that without thinking about it. Now, this is pretty clear to us when we think of addictions. For example, we think, for example, of smoking or alcohol or drug use. These are typically what we might think of as addictions. But in fact, a lot of our behavior, eating, exercise behavior, a whole range of behavior patterns that are relevant to health, actually can become habitual. And so in order to change behavior, we might need to break existing habits and then set up new habits so that the behavior is automatic in the situation where we need it. And we need quite good self-regulatory skills to break and make new habits. And one book I recommend here is David Kessler's and The End of Overeating, where he talks about food rehab, and he's talking about breaking eating habits and making new habits, and I think it's a very good account of that. So some key elements of breaking and making habits is about knowing how they are cued automatically in the environment. What is the thing in our environment that makes us likely to eat when we think we shouldn't, or drink or smoke when we think we shouldn't? What are those cues in the environment? And becoming aware of our desires in relation to those cues, feeling that we're about to give up, we're about to do the thing that we don't really want to. And Kessler calls these premonitionary urges. And another important cue here is planning exactly what you're going to do when you're in that situation, having a very clear plan, getting social support, and practicing. Practice and more practice is what's required to break and make habits. So just to summarize then, I've talked about providing people with information, I've talked about bolstering their motivation, I've talked about giving them self-regulatory skills, or a variety of behavioural skills, and finally I've talked about the habitual nature of behaviour. So this is a kind of checklist that we use when we're thinking about changing any particular behaviour. So information, motivation, behavioural skills, and habit. And here's an example of a simple intervention that illustrates some of the points that I've been talking about. This was an intervention with women who were attending Weight Watcher classes, and it was undertaken by Luszczynska and colleagues. And so here the aim was to help these women lose weight. So we judged these women to be pretty well informed, to be very well motivated. They're already coming to Weight Watchers. So this wasn't what we focused on. We focused on one simple thing, which is to help them make if-then plans about the things that derail their plans not to eat too much. So if this thing happens, this is what I'll do. Very simple planning. And we randomly assigned them to having one extra session on how to make such plans. And the question was, would this extra session help them lose weight? Now in this case, the logic model is very simple. The logic model is that if-then planning will change their eating behaviour and lead to weight loss. So there's very little in this logic model. It's a very simple one, but it still says that how the intervention is going to work is through better if-then planning. So this is an example of a very simple logic model. So here are the results of this trial. As you can see, that the people in the intervention who had the one session on if-then planning lost twice as much the amount of weight as those who didn't have that extra session over a 2-month period. So this looks like it has quite a lot of potential. It's a very simple intervention which seems to have a very good outcome. So that's the outcome evaluation for this quite simple trial. And as you can see, not only did they lose more weight, but if you look at a clinical indicator, let's say losing 5% of your body weight, then many more people in our intervention were able to reach that standard compared to those who didn't have the extra session. So from an outcome evaluation point of view, this intervention looks promising. Now from the process evaluation point of view here, what we did was we asked people in the intervention and the control group how much planning they did. And predictably, those in the intervention who we taught to do if-then planning reported much more planning of this kind. And the results of the intervention, the weight loss that I've just described, was accounted for by the extra planning. So statistically we say that the extra planning mediated or explained the weight loss. This is a very simple process evaluation, and this suggests that our intervention worked in the way that we predicted. We taught them how to do additional planning, and that seemed to account for the additional weight that they lost. Now, in this slide, I've presented a much more complex logic model. And I'm not going to go into this in a lot of detail, but I just wanted to contrast this with the previous one. This is an intervention that is designed to help diabetics avoid severe hypoglycemia. And you can see here that it's also based on the same framework, the information, motivation, and behavioural skills framework. And there are a number of changes that we want to make around their information, their motivation, and their skills. And our outcome here is that they will have less hyperglycemic episodes. So this is a logic model that we've developed for this intervention, and that intervention is now in the process of being evaluated. So these are the logic models that we need to understand how our interventions work, and in order to develop process evaluations that reveal how they have in fact worked. So just to end this presentation then, I'm just going to summarize 6 key points that I've made. So first of all, I've recommended that we use an intervention mapping approach to develop our interventions, and that we particularly plan the outcome and process evaluations. I've pointed out that we find the information, motivation, and behavioural skills framework a very useful one for developing interventions and evaluations, and that we need to add to that this issue of behaviours becoming habitual, becoming dislocated from motivation and prompted by the environment. I've recommended that we develop logic models for each intervention, and that only after that should we start developing the techniques and materials that is going to be the program itself. That's how we're going to deliver it. And finally, I just want to emphasize again that we strongly recommend that intervention development is done collaboratively, that interventions are co-created with the people who are going to deliver them, for example, clinicians, and the people who are going to receive them, whether those are patients or students. Because by developing it collaboratively in that way, you can be sure that it's going to fit into the environment in which it should be implemented. Well, thank you very much for listening. I hope this presentation has been useful to you. These are just 2 references. One's a book chapter that I developed with Sarah Denford and other colleagues at PATH, which actually summarises all the points in this presentation. And the second chapter is a chapter that's a book on health psychology, which focuses on behaviour change, and that second chapter gives a little bit more detail about the same points that I've covered in this presentation.